Good afternoon, everyone, and good morning to our viewers on the West Coast, Alaska, and Hawaii. Welcome to our webinar, Share the Risk, Advance the Response, Tools to Support Type 2 Diabetes Prevention Efforts. This webinar is part of our efforts to recognize the International Diabetes Federation's 2023 World Diabetes Day theme of Know Your Risk, Know Your Response. World Diabetes Day will be celebrated on November 14th. My name is Alexis Williams, and I will be your moderator today. I'm the lead for the Health Education and Promotion Team in the Division of Diabetes Translation at the Centers for Disease Control and Prevention. I would describe myself as an African American woman with chin-length hair, glasses, a blue cardigan, and against a blue and white background with the logo for CDC in the corner. Before we begin, I would like to go over some information about the webinar. At this time, we're required to share our disclosure statement. CDC, our planners, content experts, or their spouses and partners wish to disclose they have no financial interest or other relationship with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Planners have reviewed the content to ensure there is no bias. The content presented will not include any discussion of their unlabeled use of a product or products under investigational service. CDC did not accept any commercial support for this continuing education activity. There are no fees charged for CDC continuing education activities, and the findings and conclusions of this presentation are those of the authors and do not necessarily represent the views of CDC. This program has been approved for continuing education for nurses, health educators, public health professionals, and general CEU credits. To receive the credit, please complete the evaluation and take the post-test available at www.cdc.gov/TCEO online. A password for this activity is required, and the password is diabetes with a capital D. So note that to receive credit, you have to visit TCEO online. The link will be shared in the chat. If you've never registered for TCEO online, you will have to create a new account, and returning users should use their existing logon. During the webinar, if you have a question for our speakers, please type them in the Q&A box below. If you want to direct your question to a particular speaker, please feel free to note that in the question. We will do our best to answer all questions during the Q&A portion of the webinar. If you have a question about obtaining CE credits, where to access the webinar once it's over, or other technical questions, please use the chat box feature. So questions in the question and other technical questions in the chat. I would like to begin by asking you a question. To share your thoughts with us, please go to menti.com and enter the code 72253847 or scan the QR code. You can do this from your computer or a mobile device. If you use your computer, be sure to open a new window so you can keep the webinar session connected. We'll put the link to the Menti in the chat as well. And this will be the link that we'll use throughout the webinar, and it'll be shared throughout the presentation. So the question I want to ask is, what are some common challenges you see in your community in accessing resources and information for type 2 diabetes prevention? Please share some thoughts with us about what you've seen in your community. Let's see, loading, lack of resources, time. My eye doctor told me I have wise eyes, and it's straining of times, access to medication, lack of resources, people not knowing what's available, rural people with no transportation, people are not aware of classes, the challenges of being on the frontier or rural locations, access to new obesity drugs, bad diets, health products misinformation. People don't know what prediabetes is. So many years on, and we're still working through that. Not sure what's available, not reaching our target audience, our target populations, provider buy-in, participant buy-in, lack of interest, information in language and cultural differences. These are really great responses. Please keep them coming. I think it's a variety of both individual factors, community factors, as well as factors in the system. So there's a lot to unpack and a lot to address and supporting people and making changes to lower their risk for type 2 diabetes at multiple levels. I really appreciate you sharing that information with us. We're going to go ahead and get started. I'd like to welcome Dr. Christopher Holliday, the Director of CDC's Division of Diabetes Translation, to kick off our webinar. Dr. Holliday?
Thank you, Alexis, for serving as our moderator, and good afternoon to everyone. It is my pleasure to be with you today, and I cannot think of a better occasion to be before you as we celebrate the kickoff of National Diabetes Awareness Month. I would describe myself as a brown-skinned African American man with a salt and pepper beard and glasses, and I'm wearing a white collared shirt, a navy blue blazer with a white pocket square. I have a royal blue background, a CDC background with a watermark image of a globe and a CDC logo. The International Diabetes Federation's theme for this year's World Diabetes Day is Know Your Risk, Know Your Response. And this is calling attention to the need for expanded awareness of the importance of preventing type 2 diabetes, as well as preventing complications in individuals who have diabetes diagnoses. Approximately 96 million American adults, that's more than 1 in 3, have prediabetes. Of those with prediabetes, more than 80% don't know they have it. And yet we know that having prediabetes puts individuals at increased risk of developing type 2 diabetes, as well as other serious health conditions like heart disease and stroke. CDC has a long history of engaging with partners to support type 2 diabetes prevention in communities across the US, including through the delivery of its evidence-based National Diabetes Prevention Program, specifically the Lifestyle Change Program. While we know that this program, as well as other efforts to raise awareness of type 2 diabetes and motivate action for improved health are effective, what we do, and not everyone knows, is that everyone doesn't have the same access to reliable information and timely care to prevent type 2 diabetes. Individuals and their families need access to the information they need to make informed decisions, not only about their care, but their needed treatment. And increasing this access to life-changing and sometimes life-saving support doesn't just mean improving therapeutics. It means meeting people where they are. That's in places where they live, where they work, where they learn, where they play, and where they pray, and addressing the conditions of these physical and social environments. Those social and structural determinants of health are often enduring barriers to optimal health and well-being, causing inequities and inequalities for many communities. And addressing them is absolutely a public health priority. They are part of the Healthy People 2030 goals and one of the 4 top priorities of CDC's National Center for Chronic Disease Prevention and Health Promotion. CDC's Division of Diabetes Translation is also committed to reducing the health inequities that exist among populations that are disproportionately impacted by diabetes and at risk for type 2 diabetes. One of the ways we can do this is through development of resources that help care providers further their reach and their impact in the area of type 2 diabetes prevention. So today, we will hear about some of these resources, and we hope that you're able to identify areas where you can integrate them into your already outstanding efforts to share the risks and advance the response. Thank you for your time today, and I'll now turn it back to Alexis.
Thank you, Dr. Holliday, for opening up our webinar today. We really appreciate your remarks. Really quickly, I'm going to run through the objectives for today's webinar. We want to recognize the barriers in access to reliable information and care on preventing or delaying type 2 diabetes, identify opportunities to increase knowledge of risk of type 2 diabetes and the impact of diabetes-related complications, and connect to communities of care, apply incentives to improve diabetes-related health indicators for participants in lifestyle modification programs like the National DPP Lifestyle Change Program, as well as DSMES support services, and finally explore tools and resources to support the prevention and delay of type 2 diabetes, including the newly enhanced Road to Health Toolkit, a resource for community health workers to support African American and Hispanic, Latino, as well as Native communities. So it's a pleasure to introduce today's presenters from CDC's Division of Diabetes Translation, LaShonda Hulbert and Betsy Rodriguez. We are so happy to have you both with us today, and I will now turn the presentation over to LaShonda.
Thank you, Alexis, for your introduction. And as Alexis said, my name is LaShonda Hulbert. I describe myself as a Black woman. I'm wearing a blue shirt, a light blue shirt. My hair is blonde and brown, and I'm sitting in front of a dark blue CDC global background with the CDC logo as well. Okay, so just to introduce the topic, we know that lifestyle modification programs, like the one offered through the National Diabetes Prevention Program, can promote healthy behaviors to improve diabetes-related health indicators like body mass index and weight. The literature also shows that using incentives can be helpful to improve healthy behaviors like smoking cessation and increasing physical activity. But for this systematic review and meta-analysis, we wanted to know how incentives impact health indicators when they are provided in the context of a lifestyle modification program. So the scope of this review is to understand the effectiveness of providing incentives in a lifestyle modification program to improve diabetes-related health indicators. We looked at lifestyle modification programs that measured health indicators such as systolic and diastolic blood pressure, blood cholesterol, body mass index, body weight, and hemoglobin A1C. For the purpose of this study, a lifestyle modification program had to have at least 2 of the 3 components listed to be considered. So that includes some combination of nutrition, physical activity, or health education. And on this slide, you see our inclusion criteria for the review, such as randomized controlled trials and incentives for participants. We use the PRISMA checklist to guide this study. PRISMA stands for Preferred Reporting Items for Systematic Reviews and Meta-Analyses. It is an evidence-based minimum set of items for reporting in systematic reviews and meta-analyses, and includes the reporting of topics like the rationale for the study, objectives, and methods for the review. We systematically searched Medline, Embase, PsycInfo, and Cochrane Library for articles published between January 2008 to August 2021. To explain our analysis process further, we use the Community Guide tool to assess study quality. We use CMA software to perform statistical analysis, to assess the studies for publication bias, as well as heterogeneity. We also performed moderator analyses to examine the effect of using multiple incentive types on the health indicators of interest. And here are the incentive domains that we assessed in this review: incentive type, monetary value, recipient, frequency, attainment certainty, and schedule. Each incentive domain has subtypes that further explain the strategy. So for example, under incentive schedule, the strategy could include fixed, variable, or mixed delivery schedule. Okay, so now we have a question for you all. If you can go back to menti.com and enter the code on the screen, 7225-3847. There's also going to be a link in the chat. There's also a QR code that can link you to the question. But we just wanted to know, what kind of incentives have you primarily used in your diabetes-related programs? So cash, gift cards or vouchers, non-financial giveaways or prizes, a mixed strategy, so a combination of two or more types, or none, have never used incentives. Okay, looks like non-financial giveaways or prizes is pretty popular. A lot of people also say they have never used incentives. Yeah, not too many saying cash. This is super interesting. Looks like most folks are leaning towards non-financial giveaways and prizes. Also seeing some comments mentioning non-financial giveaways like measuring cups, portion plates, those kinds of things, which are always useful. Okay. Thank you for answering our questions. Oh, okay. Health bucks for the farmers markets. It's great. Thank you. These are some great responses. And just to move to our results here, we ended up with 19 studies that met our inclusion criteria in the review. The most frequently reported setting of the lifestyle modification programs were internet-based programs. All 19 studies reported measuring body weight, 7 measured BMI, 4 measured both systolic and diastolic blood pressure, 2 studies measured cholesterol, and 1 measured HbA1c or hemoglobin A1c. Study quality varied, but were mostly good or fair. For the incentive domain results, the most commonly reported incentive type was cash. The median monetary value of incentives was greater than or equal to $270. Most incentives were provided to individuals, provided multiple times with a criteria-based guaranteed approach, and the schedule of the incentives provided was variable. Okay, so on this slide, this is our forest plot depicting the meta-analysis results for weight. And there should be a red line, there we go, to draw your attention to the overall effect, which shows that we found that participants who received an incentive lost more weight, 1.85 kilograms, which is about 4.1 pounds, than participants who were in the control groups and did not receive an incentive. And this is our meta-analysis for BMI. We also found a greater reduction in BMI for the incentive group compared to the control group. We also observed a reduction in systolic blood pressure for the incentive group compared to the control group. And finally, we observed a greater reduction for diastolic blood pressure in the incentive group compared to the control group. And a reduction in blood cholesterol level was noted for the 2 studies that reported this health indicator, but the effect was not statistically significant. 1 study measured hemoglobin A1c, and they did report a statistically significant reduction. We did not perform a meta-analysis for these health indicators, as it would not have been appropriate due to the small number of studies. And here are the results of our moderator analysis for weight. So just to orient you to this slide, on the left side are the incentive domains that we discussed earlier and the subgroups within each domain. So we wanted to understand what impact did different incentive domains have on the health indicators that we had enough studies to measure. I want to draw your attention to the mean differences, which is highlighted on the slide, most of which show a statistically significant decrease in body weight. This means that for the most part, regardless of the incentive strategy that one might use in their lifestyle modification program, you would likely see a decrease in body weight. And though the effect for one subgroup may have been greater than the other, like monetary value, which is highlighted here, we didn't find a statistically significant difference between those domains, and those subgroups rather. For the attainment certainty domain, both subgroups had an effect on weight, and the difference between them actually was significant, indicating that the criteria-based guaranteed subgroup might have a greater effect on weight than the other attainment criteria. So overall, we interpret these findings to mean that practitioners can feel confident in their use of various incentive subgroups because they would likely be a useful strategy for reducing body weight in a lifestyle modification program. And on this slide, we saw very similar results for a body mass index. And again, practitioners, we took the results to mean that practitioners can feel confident in using an incentive strategy that works for their particular population, since it would likely, they would likely see an effect for reducing BMI when they use incentives. So in conclusion, we found that providing incentives in a lifestyle modification program is a useful strategy for reducing body weight, BMI, and both systolic and diastolic blood pressure. Future studies that include cholesterol and HbA1c could be useful to determine the effect when you use incentives to find an effect on those health indicators. For practitioners who implement lifestyle modification programs, this systematic review and meta-analysis could provide some evidence for not only using incentives, but also gives credence to flexibility in the approach, especially since the moderator analysis showed an effect on weight and BMI, regardless of the incentive strategy used. Since publishing this manuscript, we've also developed a product to complement the findings and gives readers quick and visual insights into this work. Thank you, and I will turn the presentation over to Betsy Rodriguez.
Thank you, LaShonda. My name is Betsy Rodriguez, Senior Public Health Advisor in the Division of Diabetes Translation, and I describe myself as a Latina brown woman wearing brown glasses, white and black top, and a blue hat, and I'm also having a blue background. For many people, committing to a year-long lifestyle change program is overwhelming. Sometimes you need to start with just putting on your shoes and getting into the road to health. The Road to Health Toolkit is designed for community health workers, promotores de la salud, serving African American and Hispanic or Latino communities. It provides materials to start a community outreach program to help people prevent or delay type 2 diabetes. Community health workers play a vital role in the health of the communities. With the use of the Road to Health Toolkit, they can share an important and hopeful message with their communities, which is type 2 diabetes can be prevented or delayed in people at high risk for the disease. This toolkit can help CHWs teach people that diabetes does not have to be their destiny, and it can help lead them on the road to health. In creating the original Road to Health Toolkit and in making updates to it, we completed an environmental scan and a review, as well as conducted formative and concept testing activities to gain insight from community health workers. This included intercept interviews with community health workers, as well as key informant, focus group, and pilot testing with community health workers in the field and with groups who train or support community health workers. It was also important for us to understand competencies for CHWs and their role in type 2 diabetes prevention. The Road to Health Toolkit was designed to leverage the current roles, skills, and reach of community health workers, especially in the areas of behavior change for prevention of type 2 diabetes. And in the slide, you see on the right side, the core competencies coming from the landmark workforce studies, the C3 project. And in the right side, you'll see those roles and competencies as they have been identified by the Association of Diabetes Care, Education, and Support Specialists. The Road to Health Toolkit and all its components includes the flip chart and poster were originally created to be used in person settings such as classroom, community gathering, home, and churches. Given COVID-19 and its impact in person gathering, there was a need to adapt the toolkit for virtual delivery. In addition, the content presented in the different lessons and topics needed to be updated to reflect the latest guidance and best practices in accordance with the update to the Preventive curricula and other CDC type 2 diabetes prevention resources. Some of these updates were like, for example, focus on whole food versus macronutrients, flexibility in supporting individuals in tailoring their approach to improving health and managing or losing weight, emphasis on habit formation and setting personally meaningful individual goals, and finally, more cultural relevance in both English and Spanish versions. Just as in the development of the original Road to Health toolkit, we follow a systematic process to update the toolkit. We gather insight from CHWs and other subject matter experts to inform the updating of the toolkit and to understand how it could be delivered virtually. We develop recommendations based on insights. We develop final recommendations based on concept testing and feedback. We adapt the Road to Health toolkit based on recommendations, and then we develop a dissemination plan and launch the toolkit, and we are in the process right now of promoting the use of the Road to Health toolkit. Features of the updated version of the Road to Health toolkit include increased use of active coaching strategies, including games, storytelling, and open-ended questions, activities that are very common in the so-called popular education. Guidance and sample messages for testing, messaging apps for engaging participants between sections, tips for adapting for virtual delivery, more graphics and updated layouts in both English and Spanish versions, and then printable and online interactive poster and a PowerPoint version of the participant guide. The Road to Health Toolkit English version is now available, and I do believe we're going to be putting the link on the chat box. It's www.cdc.gov/diabetes/professional-info toolkits Road to Health. The content, it has a user guide, and this guide describes all the resources in the toolkit and suggests ways to use them to promote type 2 diabetes prevention. We recommend to read the user guide first, which followed by the group leader guide, and then the participant guide, and then the activity guide. The group leader guide discusses type 2 diabetes prevention and is delivered through the story of an adult brother and sister with diabetes in their family who teach people how type 2 diabetes can be prevented or delayed. The participant guide is a resource for a group or participant. It should be used in conjunction with the group leader guide since its lessons and topics align with the group leader guide. The presentation slides are another version of the participant guide to be used as a presentation tool to display the visual of each topic during the lesson. In the original version, we used to have a flip chart. Now in this new version, this PowerPoint in a way is helping community health workers have a variety of resources that they can use based on the setting that they will be implementing and using the Road to Health Toolkit. Then it also has an activity guide. This activity guide suggests specific activities to promote making healthy food choices and physical activity among the participants. Then it also includes an evaluation guide that helps CHW plan how to get feedback from the participants and uses the information to plan future sections. And then also include video and podcast features, original musics and music videos that you can use to encourage and engage the group or participant in physical activity and movement. A list of podcasts is located on the Road to Health Toolkit website. In the original version, we used to have a CD, DVD with videos and the music. Not anyone uses those anymore. So we took all of those rich lyrics and music and portray now into a podcast and videos. Tools and worksheets also support the lessons in the group leader guide and in the participant guide, as well as the activities in the activity guides. All of these are located on the Road to Health Toolkit website. For example, you can adapt and use the slide decks to guide online lessons, to share interactive posters, or to provide participants with food and activity tracking logs. So in the slide, you can see some of the posters that are, all of these posters have been revised and updated in this new version. And they are available to be digitally used or printed. You can see here the traffic light method, the step-by-step how to prevent type 2 diabetes, and welcome to the city of solutions. In the previous version, it was called Welcome to the City of Excuses, where doing physical activity is not a priority. With these new revisions and the new input from community health workers, they suggested, what about changing from problems to solution? And now it's the City of Solutions. There are also new interactive version of the poster to use with groups or individual, especially in virtual settings. And this is one of those resources that will help community health workers to include gaming as one of the strategies to engage people in their learning process. We are in the process of posting the Spanish version to the web. The Spanish version has culturally tailored content and its own design template. So let's go now to Go Meeting. You have the code in the screen here, 72253847, or scan it so you can answer the question that we have for you all. How have you used the Road to Health Toolkit? Share your thoughts with us. Please go to the Menti or scan the QRC code. Let's see. Well, it seems that the majority of the people have never heard of the Road to Health Toolkit. Good. Now you have a new resource in your back pocket so you can share the messages at the community level that type 2 diabetes can be prevented or delayed. There are 8 that are somewhat familiar with the Road to Health old version. But the majority seems that have never heard of the Road to Health Toolkit. I'm happy to see that now we have been able to provide new resources that can be used in conjunction with the efforts that you may be doing in type 2 diabetes prevention. ADCS has done tremendous amount of work in identifying how diabetes care educational support specialists and community health workers can join forces to work toward diabetes management, but also in type 2 diabetes prevention. And I do believe that the Road to Health Toolkit can help make those connections in the environment of type 2 diabetes prevention. So how does Road to Health connect to the National Diabetes Prevention Program? Now that I have shared information on the Road to Health, you may be wondering, how does this toolkit connect to the resources available for the National Diabetes Prevention Program? Let's explore that connection. As previously shared by Dr. Holliday, the CDC-led National Diabetes Prevention Program can help people make lifestyle changes to prevent or delay type 2 diabetes and other serious health problems. And its core, it is evidence-based, it's a year-long lifestyle change program that offers participants a trained lifestyle coach, a CDC-approved curriculum as Prevent-T2, and a group support over the year. The national DPP is made possible by a national effort between public and private organizations to offer evidence-based, cost-effective interventions that help prevent type 2 diabetes in communities across the United States. The partners work to make it easier for people with diabetes or at risk for type 2 diabetes to participate in evidence-based, affordable, and high-quality lifestyle change programs to reduce the risk of type 2 diabetes prevention and improve their overall health. But what if you have someone who doesn't quite understand type 2 diabetes? What if the risk factors and how you can help prevent it? That is where the Road to Health Toolkit can be very helpful in the community, at the community level, engaging community health workers in that environment. The Road to Health Toolkit is a great way to start talking about the importance of preventing type 2 diabetes and to help people take small steps toward making healthy changes. Community health workers can find out about the National DPP lifestyle change programs online or in their area to share with people who want to make more steps toward preventing type 2 diabetes. It is well known that community health workers are the community experts. They are in the community. Many of them come from the same communities they work. They're known by people, they're trusted by people, and now you're putting in their hands resources to help them do that work at the community level. CDC has also other resources that can serve as a touch point to learning more about type 2 diabetes prevention and the national DPP. Some examples are included here, and we will put a link to hand out with these resources in the chat. To find other national DPP resources, we encourage you to visit the Customer Service Center, or CSC, at the national dppcsc.cdc.gov. You can access training materials, toolkits, and videos, ask questions, and receive technical assistance related to all aspects of the program. So, in summary, today we have explored resources that can help further efforts to reach individuals at risk for type 2 diabetes prevention and improve their health outcomes. However, we can't forget that in all the work we do, we need to keep health equity at the center. Equitable access to reliable information and care is important in both type 2 diabetes management and prevention. To learn more about CDC efforts to advance health equity in diabetes care, visit the link on the screen, and we will also put that in the chat. Thank you, and now turn the presentation back to Alexis for the Q&A section.
Thank you, Betsy and LaShonda. The questions have been blowing up. There's lots of questions and comments. I know one that I've been seeing is just about the cost of incentives. I was really excited to see on your study, LaShonda, that it almost didn't, like, monetary incentives were not necessarily better than any other kind of incentives, which makes me think it's a great opportunity to bring partners. Like, what can your partners offer you as an incentive for participants? And if the participants in today's session have other ideas about low cost, no cost incentive type items that might be offered, if they could share that in the chat, that would be great as well. But can you sort of speak to that idea of, how do you balance the cost of the program, the cost to run the program with, maybe finding incentives, if you found that information?
Yes, thank you, Alexis, for that. And yes, I agree. The questions about cost of incentive definitely are top of mind. Unfortunately, looking at the cost for individual programs was just beyond the scope of this systematic review. But what we did offer was, programs can evaluate, is this something that's cost effective for you? I think I saw someone in the chat mention, they've poured out more money than they can continue to pour out for incentives. So in that case, we did say that evaluate if it's cost effective. If it's not cost effective, you can feel comfortable, I think, to go back to the drawing board and say, hey, if we're going to continue to do or provide incentives, let's figure out a way that we're not draining our budget on something that might not be working for our population. And I really like what you said, Alexis, like, what are your partners offering? When I worked in the community setting, that was huge. Getting glucose monitors and test strips from partners, because, that was just something that people who are living with diabetes constantly need access to, and something that we could not afford to always provide them with. So yes, tapping into those partner resources, I think, is a good thing to mention for sure. I hope I answered that question.
Thank you. So Betsy, you talked about the role of community health workers. Can you speak some? There was a question about, were community health workers also lifestyle coaches, or can you talk some about the relationship between community health workers and lifestyle coaches?
Well, it is many national DPP lifestyle change programs has hired community health workers. Some of them work different from one to another, I will say, because some of them are the community health workers are using the Preventive Tool curriculum, and in providing the flavor of how CHW train and coach people, which is quite a bit different on how nurses, dietitians, or other healthcare professional or other lifestyle coaches will do it. So it is a relationship of collaboration, I will say. In many programs, they have both lifestyle coaches and community health workers. So community health workers might be in the field helping, recruiting people, increasing community knowledge about the importance of preventing type 2 diabetes, driving people to the programs, and then the lifestyle coaches, along with community health workers, are coaching those participants in the national DPP. There are other instances where community health workers are using the Road to Health Toolkit to increase awareness at the community level of the importance of preventing type 2 diabetes, and then again, driving people to the national DPP. I mean, the whole intent here is working with people where they are, reaching the people where they are, and no one better suited to do that kind of community work than community health workers. So that's why I think that it will be crucial to guide people to the practice document that the National Association of Community Health Workers has done along with the ADCS, the Association of Diabetes Care Education and Support Specialists. Especially the second one has done a tremendous amount of work putting that practice document together, highlighting how healthcare providers that can be certified diabetes care education and support specialists can work together with community health workers in the type 2 diabetes prevention arena. So, you know, we have seen the training be bilateral. Lifestyle coaches training community health workers using the Preventive Tool curriculum, and community health workers training lifestyle coaches on how to better reach especially vulnerable populations, and then the two together helping people to join the national DPP in our orchestrated effort of collaboration.
Thank you, Betsy. There are also questions about the languages. So the English version is currently of the Road to Health Toolkit is currently on the website. We're in the process of posting the Spanish language materials. Those are culturally adapted as well as in language. And then we are currently in the process of updating the American Indian version of the Road to Health Toolkit, and that will be available later next year. And again, that's culturally tailored by that community for use in those communities. So LaShonda, there were questions about the impact on retention. I think that was out of the scope of your study, but did you come across anything, or did you find anything, or have thoughts about, you know, maybe the effect of incentives on retention? And also, you know, the impact long-term, was there any indication about long-term weight loss or improvement in health indicators?
Yes, thank you, Alexis. We actually did not look at retention for this study in particular. There is, however, some other work that was completed by our colleagues in the Division of Diabetes Translation that looked at using incentives on enrollment and retention. So I will try to get that link out so folks can take a look at that if you're interested in how it can impact enrollment and retention, or some guidance on how to provide those incentives in those cases. And the intrinsic, extrinsic motivations, we didn't really get into that. However, we did mention in our discussion that it is something that's worth looking into, especially since the behaviors that one might obtain through a lifestyle modification program are behaviors that you need to sustain for a lifetime. And you're obviously not going to be incentivized over your lifespan to continue those behaviors. So our study did not do any follow-up with participants. Our study was a systematic review. So we took research from organizations that had already implemented these interventions and kind of looked at their results together. So I hope I answered that question, but we definitely did think about, or we mentioned in our discussion that, you know, taking a look at how incentives might impact someone over the long term is something that future studies should for sure look into. I think we only came across one study that really spoke to the populations that we were looking at for lifestyle modification programs and intrinsic or extrinsic motivation. So it's definitely something that should be looked into further for sure.
Thank you.
Thank you for the question.
Mm-hmm. So there's questions about recognition, and there are questions about providers engaging healthcare providers. I'm going to refer people to the Customer Service Center because we have several resources. A lot of resources that I think will help answer some questions about recognition for the National DPP. You don't need to be recognized to use the Road to Health Toolkit, but if you have questions about recognition for the National DPP, there is a wealth of information in the Customer Service Center And then there's the healthcare providers is out of the scope of this webinar, but we have some great resources on engaging healthcare providers and making referrals to the National DPP in the customer service center as well. So there was for Betsy, there was a question about community colleges and the role that community colleges could play in community certifying or training community health worker and developing community health worker programs. You're on mute.
Sorry. I think that there is a role for community college adding type 2 diabetes prevention to the areas where community health workers can expand and enhance their core skills and competencies to work in the type 2 diabetes prevention effort. In the past, we used to have Texas State Health Department develop continuing education credit based on the Road to Health Toolkit. So many community health workers were taking the credits on Texas State Health Department so they can work toward getting the certification or renew the certification. So this has been done by Texas. I will think that any college that would like to include areas to improve the workforce of community health workers in type 2 diabetes definitely can consider the Road to Health Toolkit. So as we speak right now, we're developing a training to use the Road to Health Toolkit. So it's kind of the train-the-trainer model that we used to do in present in the past. Now that is going to be digitally developed so it can serve as a source for many organizations, including college.
Thank you, Betsy. So there's a question about the role of incentives and sort of this idea of, well, you know, shouldn't people want to change their behavior? If I put on my coach health educator hat, like there's a whole lot of things we should want. We don't necessarily do because of life, because of environment, because of social structures. Incentives are one tool in the toolbox that we have to help people support behavior change. It's not the only tool, but we also know that knowledge alone doesn't result in behavior change. Otherwise, none of us would have jobs. So I don't know, LaShonda, if you have any comments about just the role that incentives can play in an intervention.
If I have a comment, it's probably related to anecdotal experience from working in a community-based diabetes organization, just because we didn't really get into that. But I will say we were, you know, pleasantly surprised that regardless of the incentive type that they use or the incentive strategy, they were seeing a reduction in body weight and BMI, which not to say that the incentive itself was the only factor. Of course, you know, there are many factors that play a role in a person's success in a lifestyle modification program. But this study really came about from our project officers in the Division of Diabetes Translation, asking, should they be recommending that our partners use incentives? And of course, you think immediately, if it makes sense, yes, use them. But we actually wanted to study that a little bit, dig into that, and really determine what type of effect we would see, and if there was any particular incentive strategy that was more effective than other. So I think finding that you can be flexible in your approach was great for me to hear, as like I said, as a person who used to work in a community setting. When you can be flexible and make it your own, so it makes sense for the population that you serve, I think that's some really good information for folks out there doing the on-the-ground work to know. Yeah, I hope I answered that question, Alexis? Was there something, did I miss something?
Well, I would like to add on my personal experience,
Yes, please.
doing prevention work at the community level. Um, in programs where we have no funds at all to do anything. One of the things that I have been, and again, this is not evidence-based comment, mostly, experiential-based comment. And I will have to say that one of the things that I have been finding that it's working so far in many communities that I work in, and this idea came from the group actually, to have some sort of testimonial nights. That's how they call it. And in those testimonial nights, in very strategic places within the communities that we're trying to reach, we have these people who are willing to share their experiences as to why the program has been helping them, how the program has been helping them, how they were able to overcome the barriers that they were putting in themselves, or any other type of barriers, and how they have been overcoming those barriers. And it seems that when people listen to other people and they can relate to the stories, it seems that something internally moved them to at least try. And we have been seeing how those people are coming sometimes at the beginning just for curiosity, and then they find out, hey, this might work for me, and they decide to stay. So they begin and end. So we have been seeing that correlation of listen to other people's story and let's try this and see if this will work for me as well as work for the others. So I just want to leave that comment in the table, because from my exploration point of view, this testimonial has become very powerful. And I call that in my program the incentives. I don't have money, I don't have anything else, but I do have people who are willing to stand up and speak up about their experiences, engaging others in the journey to prevent type 2 diabetes.
Thank you, Betsy. I think a lot of times we forget that by the time people get to us, it's probably not their first time trying to address their health or deal with their health, and so they struggle with this, and our role is to be a support and to be positive and find ways to support behavior change, and so it's to be thoughtful and kind to ourselves and thoughtful and kind to our participants is important as well. So thank you, LaShonda and Betsy. So there was a question about whether Road to Health has to be integrated with a program or can it stand alone. I know that Road to Health is a toolkit, and like I always say, a good toolkit, you can build a bench, you can build a birdhouse, you can build a doghouse. There's all kinds of things you can do with the toolkit. So could you share a little bit about some of the many different ways the toolkit is used?
Well, there are two different resources. I see this as my box when I have all the tools that I need them. Preventative curriculum is the official curricula for the national DPP. The Road to Health Toolkit it could complement the work that has been done through the preventative curriculum, especially if programs are engaging community health workers within the mix. So from one part, you have the Road to Health Toolkit that could help through the work of community health workers or all other leaders working at the community level to increase that level of knowledge, increase that awareness that type 2 diabetes is a problem. There are many people that might be having prediabetes and they don't know it. And these are the things that you can start doing. And there is the national DPP who can help you, because the science says that habit formation is not easy to happen, and it doesn't happen in a blink of an eye. So therefore, this evidence-based intervention through the National Diabetes Prevention Program cannot be taken out of the mix. So I see a complement. It's a collaboration effort where you put the community through the work that community health workers and promotores de la salud can do, and linking those communities to the national DPP. So it's a linear type of relationship, and it's a relationship of collaboration between the program and the community.
Thank you, Betsy. So we are down to the time on today's webinar. Thank you all for participating, for your great questions and comments. We didn't get to all of the questions, but we will go through them and pull together a question and answer a response to those questions that'll go along with the recording of the webinar. You'll receive a notice when it's published. If you would like to claim credit, please don't forget to go to the website, the TCEO website, to claim credit. You have until, I believe, December 4th to claim credit for the live webinar. If you have any additional questions for today's webinar, please address, you can send them to our mailbox, DDT_diabeteswebinar@cdc.gov. Happy first International Diabetes Month Day to everyone, and have a great rest of your day. Thank you for joining us.